Hey guys, so moving on to pre-malignancies and oral cancer. So quickly, just jumping straight into it, we've split it up into 5 sections. So risk factors and investigations involved, pre-malignant lesions, pre-malignant conditions, cancer itself, and then the management and treatment. So in terms of risk factors, males and increased age is a main factor. But then the most important ones are habits, so smoking, alcohol, betel quid use, and sunlight. And then clinical presentations of the lesions, so speckled lesions, verrucous, nodular lesions, any lesions in high risk sites, so under the tongue, so ventral tongue, floor of the mouth, the lingual aspect of the alveolar ridge, retromolar region, and then the posterior lateral of the tongue, and then the oral pharynx. Any large lesion or persistent lesion, so anything lasting longer than 3 weeks, is typically biopsied. And then, of course, any change in character of an existing lesion. So that's why in oral med, when we see a patient, we always tell them, okay, there's nothing to worry about, but if you see any changes, then you let us know. So if it becomes lumpy, bumpy, painful, whatnot, you come back in. So investigation-wise, all of these lesions that we're going to talk about, you biopsy them because they have a risk of being cancerous. And in the biopsy, hopefully not, but you may find dysplasia, so it could be mild, moderate, severe dysplasia. And some main histological features that you would find are, like, let's say, rete ridges in an area where there shouldn't be rete ridges, so like non-keratinized mucosa. So you can find like drop-shaped rete ridges. You would also get like dense, dense nuclei. So with uncontrolled DNA, multiplication and division. So you would get a really dense stained nucleus, and it's called hyperchromatism. You can also get different shaped nuclei and different sized cells, so pleomorphism and mesonucleosis. So shape is the pleomorphism, and the mesonucleosis is the size. And then most importantly, you'd find, I always look at the basal cell layer, so there should only be one layer of basal cells, but if that multiplying and you find basal cells like elsewhere in the epithelium, that's a sign of dysplasia. Also, if you find keratinization happening under the epithelium, another sign of dysplasia. What else is there? Mitotic activity. So if you find that so mitosis normally happens in the basal cell layer. However, because the basal cells can sometimes drift into, more superficially into the epithelium, you find mitosis happening there. And this increased mitotic activity is a sign of dysplasia. So one investigation that they do for testing mitotic activity is ploidy analysis. So this analyzes, like, if you took a bunch of cells and you analyze the number of chromatids, so 2 chromatids come together to make a chromosome. So a normal cell will have 2, so 2C, and you'll see this is the graph that spikes at 2, and then kind of 3, and then 4, and then dies. So normal cells should only range between 2, where it's normal, or if it's dividing, 4. However, in cells that are undergoing some sort of malignant change, you will find 5 sets of chromatids, 5 to 9, and the higher the range, the higher the number, the more aggressive the malignancy. So ploidy analysis for any signs of malignancy. Only difference between carcinoma, okay, I'm sure there are loads of differences, but the main 3 differences that I look at is between carcinoma and just dysplasia is, 3 signs. So one is those rete ridges that are formed. If they are invading muscle or nerves or blood vessels, that's a sign of invasion, and that's a sign of carcinoma. Or if you find that the rete ridges have gone and kind of plucked off and formed their own little island, that's a sign of carcinoma. And lastly, if you find keratin pearls, so all that keratinization that's going on, if they build up to form these pink dots in the connective tissue, another sign of carcinoma. Alright, moving on. Pre-malignant lesions. So highest risk one is erythroplakia. So I'm just gonna name like the lesion and the most main feature, just so that it sticks in your head. So erythroplakia, red lesion. It's velvety red and it's kind of slightly depressed in the mucosa. So if the mucosa is straight, it will just be slightly depressed lesion. Very, very high risk of malignancy. And then there's speckled leukoplakia, so red and white lesion. You're always going to biopsy these ones. It could potentially be a transition between leukoplakia, like idiopathic leukoplakia, to erythroplakia. Next one is idiopathic leukoplakia, so we've talked about this in the other poster. These are all white lesions that are not scrapable, and they cannot be, put into any other category, like lichen-planus, where it's like you just don't know where it's from, what it is. So it's called idiopathic leukoplakia. Most of these are benign, but like 1 to 2% have a risk of being malignant. Sublingual keratosis. So this is like found mostly in the ventral tongue, and the floor of the mouth. You get like a soft, wrinkly plaque at the underneath the tongue. Then you have proliferative verrucous leukoplakia. I mean, I would just name it in the differential, but it's not really something. Basically, you get like multiple white lesions that can become like verrucous over years. So verrucous is like, the how it looks. It's like very icky and best ways to describe it. And then smokeless tobacco induced keratosis. So smokeless tobacco is usually just held in an area, and usually the keratosis will happen in that area where it's held. So like if you're holding it in the buccal sulcus, you'll just get keratosis in that area where it's held, so you'll be able to tell where they hold the tobacco. And so you'll get white thickening of the epithelium and then potentially fibrosis. So each like type of smokeless tobacco presents in their own-ish way. So we have betel nut and areca nut. So this will usually result in submucous fibrosis, which we'll talk about afterwards. You get snus, which is the Swedish snuff. I have no idea like about drugs and like what's the difference, but apparently this one is moist, and apparently it's less problematic, and they typically hold it in their upper buccal sulcus. So you find there's like edema and like thickening and keratinization in the upper buccal sulcus. And then there's snuff dipping. Again, no idea what that is, but snuff dipping is like very closely related to development of verrucous carcinoma. Okay. So any excessive use of any smokeless tobacco will cause like fibrosis, and like if you're holding it, let's say in like the floor of the mouth, it can cause invasion, like slow invasion, causing the atrophy of the salivary gland underneath, which can then eventually lead to squamous cell carcinoma. Okay, pre-malignant conditions. So submucous fibrosis is probably the most commonish one. 4 to 8% can cause malignancy. Typically caused by betel quid and areca nut chewing. So essentially, what happens is that you'll get thickening of the connective tissue, which is the fibrosis, and you will get also devascularization, which causes it to become pale. So this is like the paleness under, usually it's like a ventral, I think the floor of the mouth. So soft palates, inner lips, buccal mucosa area. You'll become really pale, become really stiff, so your muscles are actually being replaced by fibrous tissue. And then what happens, you get like limited mouth opening, difficulty in stretching the mucosa. It becomes really tough. And then what happens is it becomes difficult to eat, to swallow, and just dentistry in general is very difficult for patients with this condition. Now, what else? Lichen planus, so very, 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 very low risk of developing cancer from lichen planus. However, if it's unusual, you biopsy it. Next one is lupus erythematosus. Again, very, very, very low risk. However, apparently, if it's like in the lower lip, then it can be a bit more likely to develop malignancy, probably because of the exposure of the sun. Dyskeratosis congenital. I mentioned this in the other poster, but it wasn't actually written down. So it has a familial tendency. It's typically like this red and white lesion in the buccal mucosa. On biopsy, it will be dysplastic. But alongside with like oral presentation, you will also get like skin lesions. You can get nail dyskeratosis, so like breaking down or any abnormality of the nail. You can also get abnormalities of blood. HPV-associated dysplasias, so any white patch infected with HPV, and then the last one is a syphilis, so again, syphilitic leukoplakia. Very rare, but you can always just mention it at the bottom, like, oh, really, really rare, but also consider syphilitic leukoplakia. Okay, cancers now. So, fun facts here up in the corner. 2% of UK cancers are oral cancers. However, in the subcontinents of Pakistan, India, Bangladesh, you'll find that it's much higher, so like I think 40%. Males are more common to get it, greater than 40, typically they present greater than 40 years old. However, with age, the risk like increases exponentially. Habits, of course, alcohol, smoking, betel quid we talked about. The most common extraoral sites of oral cancer, the most common oral cancer is actually lip cancer, is an extraoral site, but the most common intraoral site is the posterior lateral of the tongue. So lip cancer is the most common, but because it's visible, it's usually caught really early. It usually affects only half the lip, half the lower lip, and can cause like thickening, ulceration, induration, and we'll talk about spread later, but it typically spreads down to the submental lymph nodes. Two other just like side notes. One, you can get cancers like in the alveolar ridge and the palate region. Because these are so closely associated to bone, you do get invasion of bone quite early. The cheek, so holding betel quid or snuff dipping can cause like carcinomas, like specifically located in the cheek. And snuff dipping especially is closely related to verrucous carcinoma. I think I mentioned that earlier. But just quickly, verrucous carcinoma, so we know that carcinoma is invasion, right? But this one is slightly different because it spreads laterally instead of deeply. So what you'll find is that it might start in the buccal mucosa and then it'll just spread laterally. So that's why you can excise it without having to go too deep into the tissue. And histologically, you'll find like blunt rete ridges. So it would be like really thick epithelium, but all of it will be like really like rete ridges, but there won't be like space between them, and they'll be quite flat instead of V-shaped. And I mean, if it's left for too long, it can develop into squamous cell carcinoma. So those are those ones. I think the ones that most likely we're gonna come across are the ones associated with the tongue, the floor of the mouth, high risk lesions. So I've mentioned this fact before, but it's interesting if you just write it down, is that 70% of our oral cancers develop in only 20% of the mouth, so that is that high risk lesion that I was talking about. And presentation wise, so it could be like a persistent ulcer, it can become hard, indurated, it could bleed spontaneously, usually probably bigger than like 2 millimeters, can go up to 2 centimeters bigger. And again, later stages of carcinoma will invade into surrounding muscle and tissue, so your muscle around there is your tongue. If it starts invading your tongue, you can get limited mobility and you can get pain. So you'll see patients like they'll have difficulty talking and swallowing and eating, and then you end up with peg tubes and having to have excision of the entire tongue, and then speech becomes extremely difficult, and swallowing as well. Lymph node spread, so lots of carcinomas are associated with lymphadenopathy, which is one of the biggest signs. So I think really key signs that are associated with carcinoma is like that nerve involvement and lymphadenopathy, so always mention those. And if it does spread, you get enlarged lymph nodes. They're usually hard, and they're fixed. And they're usually fixed because once the carcinoma enters once it's spread to the lymph node, and then it spreads outside of the lymph node, so extra capsular metastases, it gets fixed not only to the deep tissue but then to the skin as well. And you should be able to you would be able to feel like an irregular feeling of the skin. Can ulcerate through if it's a really, really late stage, but it shouldn't. Spread. So there was a question on spread of carcinomas. So just generally, neck is usually split into, it's split into a few sections, but I think level 1, 2, and 3 are important to know. So 1 is like submental and submandibular lymph nodes. 2 is your superficial cervical chain, and then 3 is your deep cervical chain. So if you have a cancer in the posterior part of the mouth, it will spread to the submandibular, so level 1, and then it will spread down to your jugulo-digastric, so your level 2. Now, if it's more in the front of the mouth, so like a floor of the mouth cancer or the tip of the tongue, you do kind of get a drop, so it would go from like submental, so level 1, and then down to your jugulo-omohyoid, which would be level 3. Very rarely does it go down to the supraclavicular ones. However, if there's any spread to lymph nodes, typically in the management treatment, which we'll get to, they tend to do an elective dissection. They just take out all the lymph nodes. Cool. Alright, leave that aside. Management and treatment. Most of these, of course, always tailored to each of the patients individually, based on their age, the spread, what cancer it is, what they want, what they're willing to cope with. Need a multidisciplinary team, always mention that. You want the oncologist, the max vac surgeon, you want like a dentist to take care of all the pre-radiotherapy management, a speech therapist if there's gonna involve cutting of the tongue or a laryngectomy, a dietitian, and just people for moral support. So best way to kind of stage the management is to, 1, identify the dysplasia, identify the lesions, and diagnose clinically and histopathologically, make sure you know what you're dealing with. Then to identify the spread, so palpation of the lymph nodes or using a CT or MRI to scan any lymph nodes. Staging is next, so TNM staging, so tumor size, nodal involvement, and metastases. So I doubt they'll ask us, but if a stage 1 is T1, N0, M0, stage 2 is T2, N0, M0, stage 3, T3, N0, M0, or T1 or 2 or 3 with an N1. So I think N1 is only ipsilateral, so one-sided lymph node involvement. I think that's the only one that you need to know. And then stage 4 is any T4 or any N2 or 3 or any M1. So M1 is metastases, and then N2 onwards is bilateral lymphadenopathy. And then the T's are all just sizes. Go to a book and reference it. I don't remember. Then is a matter of surgery. The options are what is chemo, which is very rarely used, I think now. For oral cancer, but really it is surgery, so excisional, surgical excision, plus or minus a neck dissection if there's been lymph node spread, or radiotherapy. I think there are three cases where typically you wouldn't use radiotherapy just because you want to avoid the negative effects of it. So small carcinomas of the tongue, you can excise it. If it hasn't spread, then it should be fine. But you always want to excise it with a really wide margin, so I think 1 centimeter, if I'm not wrong. Yeah, at least a 1 centimeter margin. And then carcinomas involving the bone, you would want to try and not use radiotherapy because you're then risking the patient for future osteoradionecrosis of the jaw. And verrucous carcinoma, because as we said, verrucous carcinoma doesn't spread deeply, it spreads laterally, so you should be able to excise that without like that risk of, oh, maybe it spread deeply into somewhere else. And then radiotherapy, so the type of radiotherapy they like to use is this intensely modulated radiotherapy, so it's a really controlled, like they managed to use like a 3D image to control where the radiation is going. So this allows you, so the advantages of this is like it allows you to throw a really high dose of radiation to a very specific location without affecting all the other tissues and cells around. Because as we know, all the negative effects of radiotherapy, so what's it, xerostomia, radionecrosis, so what was that, bronch? But yeah, so you increase your chance, like, so you increase the higher dose to the tumor, and then you decrease the risks of side effects to everywhere else. And yeah, sometimes you may end up resulting in like cutting of the tongue, and a laryngectomy, and then they put like a voice box over here. But then that's all like for the management. You can add that in for like extra points or something. But generally, though, any cancer lesion, like any cancer question, I'm sure you can pretty much answer it from here. Thank you.